The COVID-19 pandemic poses a significant barrier to equal and evidence-based care for older patients with cancer. Therefore, SIOG established a specific working group, including experts from various disciplines, to develop consensus recommendations on cancer care in order to mitigate the risk of the pandemic in this particularly vulnerable population. Older adults are a very heterogeneous population that may have various degrees of functional deficits, organ function impairment, comorbidities, polypharmacy, cognitive problems, malnutrition, psychological distress, and an increased risk of toxicity on standard anti-cancer treatments. Fitness and frailty are a continuum, and geriatric assessments evaluating each one of these domains relevant to the well-being of older individuals are instrumental to inform treatment recommendations in this population. Several analyses have documented that age and cancer diagnosis are significant predictors of adverse outcomes for the COVID-19 infection. In the COVID-19 and Cancer Consortium cohort, including more than 900 patients with different malignancies and more than 50% aged over 65, the relative risk of death was 11% in those aged between 65 and 74, and 25% above the age of 75, compared with 6% below the age of 65. The TeraVolt analysis documented a significant association, again, of age with mortality in a population of patients with lung cancer. Therefore, COVID-19 represents really an additional risk to factor in decision-making. And here, geriatric assessments should remain standard of care. Geriatric assessments may aid estimating physiologic reserve, assessing the risk-benefits ratio of either providing or temporarily withholding anti-cancer treatments, and determining patient preferences. Also, 4 landmark studies recently presented at the 2020 ASCO virtual meeting show that integrated oncogeriatric care can reduce the rate of severe toxicities of anti-cancer treatments and hospitalizations, and improve older patients' quality of life. Investigators from the University of Rochester SOCARE team in the United States show that telemedicine may be an effective way to deliver geriatric assessments remotely, even during the pandemic. SIOG recommends also the use of screening tools that can be self-administered, such as the G8 or the VESTER-13, in order to identify patients requiring a more detailed evaluation. Regarding specific anti-cancer therapy approaches, the decision-making should really be individualized and take into account the potential risk of pursuing, delaying, or omitting specific treatments, and or pursuing alternative treatment options. When it comes to surgical decision-making, the most secure and safest approaches to achieve local disease control should be prioritized. Open and endoscopic techniques might be considered, and the expected morbidity, mortality rates, and recovery time, the availability of resources, including anesthetic input, ICU, and operation theaters, the chances of disease control or progression with delayed approaches, and the presence or absence of cancer symptoms should be taken into account. Emergency procedures, and those where a delay could cause significant negative impact on cancer outcomes, should still go ahead. On the other hand, delaying surgery might be appropriate for older patients with ER-positive, HER2-negative early breast cancer while pursuing neoadjuvant endocrine treatment approaches. In selected cases, when the impact of surgery on symptom control and also survival is deemed marginal, omitting surgery and pursuing primary endocrine therapy might also be considered. Regarding radiotherapy, doses and fractionations can be adapted in these circumstances. In the curative setting, hyperfractionated regimens might be preferable to reduce the need for hospital visits for patients with early-stage non-negative breast cancer based on the recently published fast-forward study results, but also for patients with early prostate cancer. Neoadjuvant radiotherapy should be favored over a more prolonged course of chemoradiotherapy for patients with locally advanced rectal cancer. In the palliative setting, a single fraction of radiotherapy should remain standard of care for the purposes of bony pain relief, and in the case of metastatic cold compression. Radiotherapy can also be delayed where there is evidence that this does not affect cancer outcomes. For example, for patients with early-stage breast cancer, it can be delayed for up to 5 months. For those with early-stage prostate cancer, for up to 2 or 6 months, based on the biology of the disease, and with the help of using upfront androgen deprivation therapy. Radiotherapy can also be omitted where the survival benefits are less clear. For example, in older patients with low-risk early-stage breast cancer. Stereotactic radiotherapy may also be particularly valuable in this setting to limit the number of treatment fractions and required hospital visits. For example, it may be a reasonable alternative to surgery in selected patients with stage 1 to 2 non-small cell lung cancer. With regards to systemic treatments, risk may be higher for patients requiring myelosuppressive agents. And again, decision-making should be individualized based on patient preferences and health status, tumor biology, type of agent, local prevalence of COVID-19, and risk of exposure to the infection. Models based on genetic assessments are available to predict the risk of severe toxicity on chemotherapy agents, such as the CRASH model validated by investigators at the Moffitt Cancer Center of Tampa, Florida, and the Cancer and Aging Research Group model validated by investigators at the City of Hope Duarte in California. In the curative setting, chemotherapy should be pursued in the presence of clear survival benefits, which may be less established in the older patient population. In the palliative setting, shared decision-making is crucial and should take into account the potential impact of quality of life and functional status, and alternative non-myelosuppressive agents should be considered if available. The use of primary G-CSF prophylaxis should also be mandatory in this setting. Regimens requiring less frequent dosing should be considered, such as, for example, Capox instead of FOLFOX for colorectal cancer. Oral agents should be favored over intravenous regimens, such as capecitabine instead of 5-FU for colorectal malignancies. Shorter courses of systemic treatments should also be prioritized, such as 3 versus 6 months of adjuvant chemotherapy for stage 3 colon cancer, or 6 versus 12 months of trastuzumab for early-stage HER2-positive breast cancer. In the adjuvant setting, systemic treatments can be safely delayed without compromising efficacy within different timings based on each tumor type. For example, for early-stage colorectal and lung cancer, chemotherapy can be delayed for up to 8 weeks. For patients with early-stage breast cancer, for up to 12 weeks. Chemotherapy should be omitted where there is no clear survival benefit, such as in the case of older patients with early-stage luminal breast cancer. The COVID-19 pandemic is rapidly evolving across the world and is having a significant impact on the care of older adults with cancer. International collaborative research is warranted to elucidate the outcomes of the infection in this population and its effect on cancer outcomes in this age group. However, chronological age alone should not drive treatment recommendation in this setting, and geriatric assessments remain key to better inform and shared and evidence-based decision-making.